All right, so Ivan, can you talk to us about biceps tenotomy versus tenodesis? Who gets a tenotomy and who gets a tenodesis and why?
I actually let the patient decide usually.
You just have to hold the mic up and look forward. Don't talk to me, talk to the webinar people.
I generally like to let the patient decide. I've got a ruptured long-headed biceps myself on my right side, and I show the patients that and say it's possible that they might end up with one of those.
So then right away they ask for a tenodesis.
Right away they ask for a tenodesis. Yeah, but I mean, I inform them that like, the biceps tendon is not that functional, especially in the older patients. In younger patients, tend to do a tenodesis, but I think tenotomy in patients 40 and over do very well. The only one proviso is occasionally people do get spasm if they're doing a lot of supination, pronation. So if they're like a mechanic, manual worker, they may be better off with a tenotomy. If they tenodesis, if they do have a tenotomy and do get that spasm, or if they've got a long-headed biceps rupture that's treated non-operatively and they do get spasm that doesn't settle down, then you can always do a tenodesis down the track. So the main reason for doing the tenodesis, though, is cosmetic.
Okay. Todd, the concept of adhesive capsulitis after a rotator cuff repair. Look, we know it's actually not adhesive capsulitis because that's a specific disease process which may be autoimmune and goes away after a couple of years. So we're really talking about shoulder stiffness after a rotator cuff repair. Do you have any strategies for dealing with that?
Yeah, well, I think that patients after arthroscopic rotator cuff repairs, stiffness that they get after surgery doesn't really become a major issue. And so I try not to get too concerned about it early on. So some people might get quite stiff in the first 3 months and usually tell them not to stress too much about it. And I think that's the key. I think that it would be wrong to bring them back and manipulate their shoulder. Some studies show that in 12 months, most of this stiffness will resolve. So certainly I'd let that wait and let them continue their postoperative protocol with getting as much motion as they can without overdoing it and causing too much pain. So.
And I remember Jerome used to always say to me, congratulations, you've got a stiff shoulder. That means your rotator cuff's healing well. And it's going to take you a year or so to get the motion back, but don't stress. So, I've always taken that attitude with the patient. You tell them, look, it's fantastic that your shoulder's stiff now. As long as you're not stiff at a year, it doesn't matter. Anything different with that, Ivan?
No, I agree with that. It's a self-resolving condition, and it's good if everyone just relaxes about it. Aggressive stretching doesn't help, just irritates the patient and makes them miserable.
Yep. All right. So you've got a patient that comes in with an ultrasound showing a full thickness cuff tear. You examine them, you've decided they've got weakness there. Are you prepared to operate based on an ultrasound only? I might start with you, Todd. Or do you want an MRI on every rotator cuff tear?
Good question. Well, I pretty much...
I only ask good questions.
Yeah, I pretty much always get an MRI. It's very accurate. It'll show you the extent of the tear, and it'll show you the repairability of it. Your exam is more accurate than the ultrasound. And so if an ultrasound says you have a tear, but your exam shows no weakness, then you definitely don't operate right away. I definitely get an MRI because it's possible they won't have a tear and they just need conservative management. So you never trust the ultrasound results. That's my take-home message.
Ivan?
Yeah, I always get an MRI. Ultrasounds are wrong about half the time in relation to full-thickness rotator cuff tears. Even if they're correct, they don't give you enough information to adequately plan the operation. They give no information regarding tendon quality, muscle atrophy, degree of retraction, and associated injuries. They're totally useless.
Yeah, and the ultrasound can't see in the shoulder. You don't know whether there's any arthritis in the joint. You don't know how, as you said, fatty atrophy or how many tendons are often involved. So I agree 100%. All right. Ivan, is anyone too old for a rotator cuff tear? Is there a cutoff beyond which you won't go?
Well, not really. I mean, I think this concept of like putting an arbitrary age number on someone and saying after this, too bad is fallacy, and particularly as my numbers are getting larger. So I think, there are, what really is, it's the response to non-operative management, and then any concordant other pathology in the joint. Like if patients are getting older, they're developing arthritis in the presence of rotator cuff repair that's not amenable to non-operative management, then you start thinking more about reverse shoulder replacements. But there are patients with rotator cuff tears, if they're not getting better with non-operative management, they're miserable, they're in pain, they've decreased function, and they deserve an operation to get them better if that's appropriate.
Thanks, Ivan. So, Todd, I'm going to ask you the question, but I'm also going to give you a bit of pre-information. What's the point that the physiotherapist's threshold to stop treating the patient and send them on for a surgical opinion? Now, I'm not talking about someone that has an acute injury. So the person that has the acute injury falls over, is unable to lift their arm up. Clearly, that just needs to go straight for imaging and treatment. But I'm talking about the patient that maybe didn't have much of an injury, but just has sort of a chronic thing, but when the physiotherapist sees them, they do have impingement pain and they do have some weakness. How long can the physiotherapist keep treating them? And what's their threshold to say, okay, now you should seek an opinion?
Well, so we're talking about the person with chronic shoulder pain, not an acute injury.
Yes.
So first of all, I guess it has to kind of look like an impingement. It can't be some obscure type of pain, or else you probably want an x-ray or a workup for what the cause is. But if it looks like impingement, they have chronic problems, you're going to start doing some physiotherapy, but they also can be benefited by cortisone injections. So I'm kind of thinking they should go sooner rather than later, so they can get cortisone injections, they can get some advice about what they have, things like that. I'd probably say, generally speaking, if we're going to treat, let's say, a partial cuff tear, and we're going to talk about conservative management, we usually would say try it for 3 to 6 months. So you could do that if that's what you really know you have, and you perhaps had an x-ray or an ultrasound from the GP, and the exam suggests that, then I guess 3 to 6 months if you have that. But if there's any question at all, I'd just refer them on just to make sure that they're dealing with the right thing.
Ivan, any different thoughts on that?
I think if they're a compliant patient, diligent with the exercises, and they haven't made significant improvement in 3 to 4 months despite appropriate non-operative management, I think those people will be reasonable to refer on for further assessment.
Yeah, and I think one of the keys as part of your talk as well, you talked about the weakness on clinical examination. And I think if the patient continues to have weakness despite the exercises, I think that's probably a signal to you that you should be serially testing their motor power. But if they're not restoring motor power, probably they need earlier assessment than if they're getting better with the treatment. Do all partial cuff tears need surgery?
Definitely not. I usually treat partial cuff tears non-operatively initially, so they would get physio for 3 to 6 months and cortisone injections to help their pain. I know there's been some resurgence of this Regentin for partial cuff tears lately, where people are getting quite aggressive, but I haven't found that that's very effective, and I have not tried that.
Well, I spoke to one of the people involved with the study, and he has stopped using it because he found that it made the shoulder too inflamed afterwards.
Yeah.
So
I've seen very bad complications with it, and like you said about the musculocutaneous nerve in Latarjet's, I think when we talk about complications, we need to talk about the catastrophic complications. Because, if I told you could fly business class, but your plane might crash 1% of the time, I don't think you'd want to fly business class. I think you'd stick with economy, wouldn't you, if you had a less rate of failure?
It's kind of, well, if you're in the same plane, I'm not quite sure about your analogy. Maybe that's an American analogy, but I kind of get what you mean.
We're talking different planes.
Yeah. So you walk backwards onto the plane, so you can still turn left rather than right. All right, Ivan, how many cortisone injections is too many? And does it damage the rotator cuff and then interfere with an operation?
Well, like I said in my talk, there is evidence that corticosteroid injections can inhibit healing, particularly multiple injections. I think it's more looking at but the other side of things is they can be a very useful adjunctive treatment modality to allow patients to perform their rehabilitation. So I think they need to be combined with appropriate physiotherapy, and I don't personally do that many. I think at one, maybe two, possibly three if the outside of the patient's very surgical adverse. But at that stage, if you're separating by 6 to 8 weeks apart, you're like, you're up to 4.5, 6 months of appropriate non-operative management. If they're not better by then, they're not going to get better. So I think I prefer 1, maybe 2. Sometimes I get my arm twisted 3, but I think there is a downside to corticosteroid injections, although they are very useful, particularly in the acute phases.
And don't forget that there's actually no evidence that there's a difference between an ultrasound-guided corticosteroid injection and just given in the office by the physician. And in our group, we tend to just give the injections ourselves because we give a higher volume injection. Most of the radiologists that give 5 mils, we'll give 8 mils of 1% xylocaine and 2 ampules of celestone. So a lot of patients that have had failure of injections elsewhere will end up having a successful injection because the subacromial space is very big and it can take 200-300 mils of fluid. And if you only put a little bit of fluid, that injection doesn't always work. So failure of an injection is not necessarily failure of the injection unless you know they've been given the right dose. Anyway.
The other thing is they're often a lot less painful because you've got a radiologist with an ultrasound machine going like this, whereas it's a very easy shot. You can just throw it in and it's easy.
All right, so just to wrap up.